So I'm going to get started unless there's any immediate questions by the video from Dr. Lee.
Good morning, everyone. My name is Ina Lee, and I'm a neuro-oncologist and neurofibromatosis specialist at Mass General Hospital. It's a great pleasure for me to be here today to tell you about our efforts of using artificial intelligence to improve care for patients with NF1, and specifically our work in applying AI to improve care for individuals with plexiform neurofibromas and malignant peripheral nerve sheath tumors. Plexiform neurofibromas arise from the peripheral nerve sheath. They are a common type of tumor in people with NF1, affecting up to 60% of individuals. They can be located superficially, as seen here on the left, where they are often accompanied by characteristic skin changes such as hyperpigmentation and thickening of the skin. Or they can be invisible to the naked eye and be located deep inside the body. And in that instance, the only way to know about these deep tumors is if the patient undergoes an MRI scan. Here you see an MRI scan of a person with multiple tumors arising from the spinal nerves and nerve bundles supplying the upper extremities. Plexiform neurofibromas are benign or non-cancerous tumors, but nonetheless they can cause significant problems. They can cause morbidity by causing pain, neurologic dysfunction, functional impairment, and disfigurement depending on their location and size. A subset of plexiform neurofibromas can also transform into a malignant peripheral nerve sheath tumor, or MPNST, which is a type of aggressive cancer. So to summarize, the major risks associated with plexiform neurofibromas are A, the risk of tumor growth, and B, the risk of transformation into an MPNST. Today, I'm going to share with you some of the work we have done to better distinguish benign plexiform neurofibromas from MPNSTs. Before I do that, however, I would like to briefly discuss what artificial intelligence actually is. AI is a field of science concerned with building computers and machines that can reason, learn, and act in such a way that would normally require human intelligence, or that involves data whose scale exceeds what humans can analyze. It uses computer algorithms to dissect complicated data. AI has many potential applications in science and particularly medical imaging. If you think about an image or photograph, such as the image of this laptop, it consists of many small components known as pixels or voxels. It's ultimately the constellation or arrangement of these pixels and voxels that create the image. In medical imaging, this constellation can be very complicated. What AI does is it can help identify imaging patterns that the human eye cannot identify on its own. And by doing so, AI can potentially help in the early identification and characterization of disease. So as mentioned, one of the major questions that we have been trying to address is, can we use AI to better distinguish between benign plexiform neurofibromas and MPNST? As I already alluded to, peripheral nerve sheath tumors in NF1 exist on a spectrum. They range from benign plexiform neurofibromas to atypical neurofibromas to malignant peripheral nerve sheath tumors, or MPNSTs. MPNSTs are the leading cause of premature death in people with NF1. And in fact, most MPNSTs arise from a pre-existing plexiform neurofibroma. Early identification of MPNSTs is important because it allows us to offer potentially life-saving treatments to patients. Currently, magnetic resonance imaging, or MRI, is used to monitor plexiform neurofibromas. MRIs typically include STIR and T1 sequences or images. Clinicians look at descriptive MRI features such as tumor margins and contrast patterns on STIR sequences to assess whether a tumor is more likely to be benign or malignant. For instance, a tumor that has irregular borders or a mixed or heterogeneous contrast pattern typically raises concern for a malignant tumor. However, you can see from these images that there is significant overlap between benign, atypical, and malignant tumors. So current descriptive MRI features are not accurate markers of underlying tumor histology. Therefore, the question arises, can we develop a tool using clinically available MRIs that allows us to reliably distinguish between plexiform neurofibromas and MPNST? To address this question, we are applying a tool called radiomics. Radiomics is a form of machine learning, which itself is an application of artificial intelligence. In machine learning, a computer algorithm is given lots of data, called training data, to learn patterns that are different between groups of diseases. And through this process, it is then able to make predictions when exposed to new data. Using radiomics, the computer algorithm extracts quantitative imaging features from MRIs that may not be evident to the human eye. This figure here illustrates the typical radiomic pipeline. We start with segmenting the tumor on the MRI scan. A computer algorithm then extracts quantitative features such as tumor intensity, shape and size, and tumor texture or heterogeneity from these images. The algorithm is looking at features such as how bright is the tumor, how round or irregular in shape is it, and how much do the voxels differ from one another, which is generally referred to as tumor heterogeneity. The computer is then trained and learns from experience and selects the features that are most predictive of the presence or absence of an MPNST. To develop a radiomics model that can differentiate between plexiform neurofibromas and MPNSTs, we first had to collect a sufficient number of MRI scans. Machine learning works best with a large number of data, so we collected MRI scans from 9 centers in the US and Europe, listed here. For the development of the model that I'm showing you today, we included 136 plexiform neurofibromas and 91 MPNSTs. The first step in model development was to segment tumors on STIR and T1 images. Next, we performed image preprocessing and standardization. This is important to harmonize differences in MRI scanners and imaging protocols between and within centers. We then extracted radiomic features from the images and selected the top 10 most important features. These features were then used to build a random forest model to distinguish between plexiform neurofibromas and MPNSTs. 70% of the data was used to train the model, and 30% of the data was used to test how well the model would perform in the real world. We looked at 3 models, one based on STIR and T1 images alone, and one based on both together. The primary metric to evaluate model performance is a statistical measure known as the AUC, or area under the ROC curve. I want to draw your attention to the test set because, again, this is the true independent evaluation of the model's performance. The STIR model had an AUC of 0.807. This means that there's an 80.7% chance that the model will correctly classify tumors as plexiform neurofibromas or malignant peripheral nerve sheath tumors. As you can see from this gray box at the bottom, this corresponds to good performance. The T1 model performed less well with an AUC of 0.744, meaning that using T1 images alone, the model correctly classifies tumors in only 74% of cases. Lastly, the best performance was seen if the computer algorithm learned from both STIR and T1 images. The AUC for this combined STIR and T1 model was 0.836. This means that there's an 83.6% chance that the model will correctly distinguish between plexiform neurofibromas and MPNSTs. Again, this would be considered good performance. To conclude, our preliminary radiomics models are able to classify tumors as plexiform neurofibromas and MPNSTs using MRIs that are routinely acquired in clinical practice. The performance was best for the combined STIR and T1 model, with an almost 84% chance of correct classification. So where do we want to go from here? The ultimate goal of this work is to translate machine learning into the clinic. So we envision a scenario where we would integrate our radiomics model into the clinical workflow to help with early identification of MPNST or premalignant atypical neurofibromas. There are also opportunities to use AI-based methods to answer other important clinical questions related to plexiform neurofibromas. For example, we will be working on a model to identify plexiform neurofibromas that will grow in the future using deep learning, another type of AI. This is important because it will help us identify patients who may benefit from early treatment interventions. Another potential area of study may be leveraging AI to identify patients who will or will not respond to therapy. This is particularly important in the era of selumetinib because we know that not all tumors respond to treatment. So knowing who will respond can help with patient selection. Conversely, knowing who will not or unlikely respond can help avoid exposing patients to the potential side effects of treatment. Lastly, our radiomics pipeline and other AI-based methods could be applied to other types of NF1-related tumors, such as cutaneous neurofibromas and optic pathway gliomas, or other types of NF1-related manifestations, such as scoliosis. I would like to thank all my collaborators for their tremendous support and help in collecting this data set and for enabling this kind of work in the first place. It was truly a team effort. And I'm also very grateful for the support and resources that I have received from NTAP, or the Neurofibromatosis Therapeutic Acceleration Program. Thank you very much for your attention.
So I wanted to bring up a couple of points. So the reason why we do